Induction of labor is a very small but important topic in obstetrics. So we have seen the indications so far in our discussion, like when do we induce a baby and preeclampsia, some 30 weeks, some 34 weeks, some 32 weeks. So in gestational diabetes also there are certain indications, and in terminating a pregnancy. So that is all about timing and indication. Now, what are the methods of inducing labor? So it can be either mechanical or surgical or pharmacological. So basically, induction of labor is like pushing a lady who is not in labor into labor, who is already in labor, to intensify that labor is known as augmentation of labor, which is mostly done by oxytocin or artificial rupture of membrane during labor. But induction of labor is when somebody is not in labor to push that person into labor. So there are two parts of it. One is the effect making the cervix more ripe and more dilated, and the other one is increasing or inducing uterine contractions. So we'll see the methods one by one and try to understand how that works. So mechanical methods, basically what they do is they are mechanically ways to mechanically dilate the cervix. So basically imagine this is the cervix, and if we put a hygroscopic material inside, and put water inject water into that, this will slowly take up water and dilate, and dilating the cervix at the same time. So these kind of devices, if it is organic from made of a certain seaweed, it is known as laminaria. If it is a synthetic one, it is known as dilapan. Remember, dilapan is a very important clinical question for INI exams. And then there is Foley, age old urinary Foley catheter, which we can put inside the cervix between the external os and internal os, and inflate it with 40 to 60 millimeter of 60 cc of water, and we can keep a traction on the leg so that the Foley balloon is forced to come down slowly through the os, and as that 60 cc balloon is coming out through the os, it keeps the it dilates the os and comes out, right? Surgical is of course ARM, which is not preferred, because ARM is a one-way journey. ARM is a one-way journey towards induction of labor, because once we have done ARM, once the LICA starts leaking down, we cannot reverse the process. We have to deliver her. So if she cannot deliver, if she doesn't go into labor, we need to do a cesarean on her unnecessarily. So ARM is mostly reserved for augmentation of labor, or for those in whom we are already very much determined that we will deliver this baby within a certain amount of time, like preeclampsia with severe features. We are sure that we will not wait for a long time. We have to terminate this baby within 24 hours. So we can start with ARM. If she delivers, good. Otherwise, we'll do cesarean. So better to do the ARM early and give them the maximum time of the progesterone surge that happens with ARM, but mostly ARM is not preferred. So regarding the pharmacological agent, I would specifically like to talk about three prostaglandins. Prostaglandin E1, which is known as misoprostol; prostaglandin E2, which is known as dinoproston, and this is available in two formulations: jelly 0.5 mg to be applied in posterior fornix, or a pessary known as ProPress pessary, which is of 10 mg dose. So this is 0.5 mg, this is 20 times higher, and this is to be kept in the posterior fornix as well, and not for induction of labor, just as a completion sake. I'm talking about the third progesterone, which is a prostaglandin, which is PGF2 alpha. So let us discuss the agents now. If I make a chart, miso, dino, and prostadine. Prostadine is also known as carboprost. It is not used for induction of labor and used for PPH control and second trimester abortions. So, effect on cervix.